Today we're going to talk to you about substance use disorders primarily in children and adolescents. The following are the main objectives for this presentation. Please take a moment to answer the following questions prior to starting. Please note you will also complete this test again following the presentation to test your knowledge of the presented material.
This presentation is guided by constructivist learning theory. This is an active learning process, and it's ideal for adult learners such as us because it allows students to actively create their own learning based on individual previous experiences. So you have all seen some material on substance use disorders in previous courses, and you've encountered and treated these conditions in your clinical settings. But today we're going to be applying what we already know about substance use disorders to a new population for many of us, which is adolescents and teens. Feel free to skip through sections that you feel like you have a really good grasp on and focus on ones that maybe are new to you.
This slide includes categories of substances as listed in the DSM-5. Those highlighted in yellow are the ones most commonly abused among children and adolescents. Among children and adolescents, the most commonly abused substances include alcohol, cannabis, and tobacco. However, substance use in this population is not limited to only these three categories. The average age of onset is 13 to 15 years old in substance use disorder for adolescents, with a 2-to-1 male to female ratio except in tobacco use. The two bottom statistics are important when considering risk factors for developing a substance use disorder. There are several factors which may play a role in the developing of a substance use disorder. One major biological factor that contributes is the neurodevelopmental and/or neurobiological changes that can occur in the brain after an individual is exposed to a substance. Therefore, the earlier a person begins to use a substance, the greater the chance changes will occur in the brain, especially in children and adolescents whose brains are still developing. Many research studies also look at genetic factors for causes of substance use. While there is definitely some evidence that genes play roles in the development of addiction, environmental and social factors appear to be the most important. Some social or psychological factors include adverse childhood experiences like abuse, neglect, or traumatic events. Individuals with co-occurring mental illnesses, especially those undiagnosed or untreated, may also be at higher risk for developing substance use. And then individuals who come from poverty or lower socioeconomic status are also at a higher risk, which is likely due to the physiological and other important needs not being met, and they tend to experience greater hardship. The following are a list of risk factors providers should be aware of that make the development of a substance use disorder more likely in the adolescent population. These are some protective factors that may help an individual avoid development of a substance use disorder. This is a short video that you can watch to improve your understanding and insight into the neurobiology of addiction. Recall that the mesocorticolimbic dopamine reward pathways are the primary underlying pathways in the development of addiction and include projections from the ventral tegmental area to the nucleus accumbens. Most of the substances that are abused target this area of the brain and release dopamine, which stimulates a feeling of euphoria. Additional areas of the brain activated in addiction include the globus pallidus, which plays a role in habit forming and automatic behaviors, as well as the PFC, which is important in executive functioning and decision making. Besides dopamine, glutamate is also released, which plays a role in memory formation of the drug experience and desirable feelings, which may contribute to drug cravings later. When drugs significantly increase levels of dopamine, the body naturally compensates after it is withdrawn, and there is a dip, which creates unpleasant effects for the user. Some systems in the extended amygdala are also occurring when an individual begins to use the substance more, and this may create further undesirable effects to the user, which may prompt them to engage in more use to avoid these effects. Ongoing chronic use results in further loss of functioning of the PFC. It's also important to keep in mind that earlier an individual is exposed to substances, such as in children and adolescents, the more likely early neurodevelopmental changes will occur, making it more likely to develop into a substance use disorder. In order to meet criteria for a substance use disorder, individuals must have at least 2 of the following criteria that we will discuss over a 12-month period, and there must be a significant impairment to the person's overall functioning. In all substance use disorders, the first 4 criteria are focused on impaired control in relation to the substance use. Criteria states that individuals will use more of a substance than intended or take it in excess amounts. They may feel bad about their use and try to reduce how much they are using or not be able to stop using it altogether. They will spend a significant amount of time trying to get the substance, use it, or recover from it, and they may experience intense desires, urges, or cravings to use the substance, which happens more frequently when you encounter similar environments or experiences that you had while using the substance. Criteria 5 through 7 is focused on impairment in different domains as a result of the substance use. When individuals experience substance abuse, this may begin to negatively impact their daily roles at work, school, or home. After these areas are negatively impacted, individuals will continue to use regardless of the consequences and eventually may completely stop certain activities or significantly lower their participation as a result of continued use. Examples of this may be messing up at work, then using more substances at home regardless of this, and then eventually missing going to work altogether. Criteria 8 through 9 talks about risky use. In these areas, individuals may put themselves in compromising positions in order to obtain the substance or to continue to use it. For example, going into a bad neighborhood to go get the substance. Additionally, people may experience a physical illness as a result of the use but will continue to use regardless. The last criteria focus on the physiological effects that occur as a result of substance use. Tolerance occurs after an individual is continuously exposed to a substance and over time requires more of it to achieve the same effects as you previously did. So previously an individual may have gotten tipsy from just 3 drinks, but now to get that same effect, it may take about 6 drinks. Withdrawal is marked by the physiological effects that occur after a person stops a substance they previously were exposed to for a while. Initially, when a person stops, they may not experience immediate effects, but as it slowly leaves the blood or tissue, the effects may begin to occur. The severity of these effects will vary depending upon the different substances that are abused and how they affect the body. The next slides will provide some demonstration into potential effects that may occur during drug intoxication and/or withdrawal. We won't go over the next few slides, but these will provide some insight into potential intoxication effects and withdrawal symptoms that you may see among different substances. When reviewing, think about the concept of what goes up must come down, and vice versa. Certain drugs will cause certain effects when a person does them and becomes intoxicated. However, as individuals use these drugs more and more and build up a tolerance, when they begin to withdraw from a substance, they will experience the opposite effects of intoxication. So in the case of a benzodiazepine, for example, which works similarly to alcohol, their intended effects are to relax you, maybe help you sleep, has an anti-seizure effect, and keeps you calm. But for the person who becomes dependent upon these medications, they may then in turn experience mania, insomnia, or have seizures when they're withdrawing. The next slides will continue to show some demonstrations. When we start to discuss assessment, part of this is knowledge and awareness of what symptoms you may see in a person who may be intoxicated or having withdrawal symptoms. Providers need to complete both a comprehensive psychiatric and physical assessment. This is extremely important, especially when needing to assess for potential comorbidities and effects of ongoing substance use. These assessments will also help to identify risk factors and barriers to treatment. Components of the psychiatric evaluation include identifying data, the patient's chief complaint of what they think is going on, the history presenting illness, a review of systems provided by the patient, medical and psychiatric history, substance use history, which would include the types of substance that they're using, how often they're using it, etc., family history of mental illness and substance use, social history, and objective information from the mental status exam, including vital signs, and then an assessment and plan will also be done as part of the psych evaluation. The mnemonic HEADS can be used to help with the social history. This stands for home and environment, education and employment, activities, drugs, sexuality, and suicide and depression. A physical evaluation is also important to assess the patient's physical functioning and determine the need to address physical findings that may have occurred as a result of ongoing substance use, and can also help identify barriers to treatment and comorbidities. There are several screening tools which can be utilized to assess for substance use disorders and the risk for substance use in adolescents. The American Academy of Pediatrics recommends that all adolescents and children be screened at every health visit to identify risky substance use early. The S2BI and BSTAD are two good examples of free validated tools that can be accessed electronically and used for adolescents, which includes the option for either a self-assessment or for interview or administration. Diagnoses are based off the DSM-5 criteria and will be given based on the type of substance that is being abused. Diagnoses may also occur based off of intoxication, dependence, general use disorder, or potential substance-induced mental disorders, meaning that a person may be experiencing symptoms of a mental disorder, but it is exclusively due to the effects of the substance use. Other unknown substance-related disorders may be used when there's an unidentified substance that's not listed in the DSM-5, or occasionally you may see a provider who will use this as a way to label polysubstance abuse when they're using more than one substance. Differential diagnoses are those that we may be working to rule out and or can include some of the patient's potential comorbidities. For example, it may be difficult at first to distinguish if a person is having both major depression and a substance use disorder versus just depression as a result of the substance use. That may not be present in the context without it. Regardless, providers want to make sure that they treat all disorders appropriately and be mindful of patient safety.
For adolescents and teens, psychotherapy is the first-line treatment for all substance use disorders. Many teens with substance use disorder have underlying comorbid psychiatric conditions, and this is likely why psychotherapy is often more successful than medication to treat their substance use. Therapies with the most data to support their use in this population include motivational enhancement therapy, cognitive behavioral therapy, contingency management, and various family therapies. Family-based treatments are the most strongly supported psychosocial intervention for adolescents with substance use disorder. This type of therapy directly addresses interpersonal relationships across multiple settings, so families, peers, school, and even legal issues. The goals of this type of therapy are to increase functioning in multiple contexts, so family and social, improve parent monitoring and supervision of their child, strengthen communication between family and their different social systems, and strengthen their ability to cope, communicate, and make good decisions. There are 4 types of family-based therapies that are recommended for the treatment of substance use disorder, and we will go through all of them in just a second. So the family-based treatments that are recommended for the treatment of substance use disorder in teens are multidimensional family therapy, functional family therapy, brief strategic family therapy, and multisystemic family therapy. The goals are all the same, like we just talked about, but they use different techniques to get there. And one thing to note is they go from kind of least intense to most intense. So if you notice that multisystemic family therapy requires multiple sessions and hours per week, and the therapist really gets involved in multiple components of the child's life. Contingency management uses motivational incentives like prizes and vouchers to reduce substance use. It's based on the principles of operant behavioral conditioning. For teens, the rewards should be tailored more towards their aesthetics. You can think of things like concert tickets or gift cards to cool stores, things that kids would actually like. While this form of therapy is used pretty often in adults, clinical trials on contingency management in teens does have pretty mixed results. Overall, there's adequate research to support the effectiveness of contingency management for teen substance use, but these positive effects are pretty short-lived, and for this reason, contingency management is often added to other types of therapy, like CBT. CBT is a great modality for substance use treatment in adolescents. We know that CBT focuses on changing our thoughts to ultimately change our behaviors, and it accomplishes this by boosting our coping skills, problem-solving, and decision-making abilities. What we like about CBT for this population, it can be delivered individually or in group format, as well as both inpatient and outpatient. It's accessible to most patients. It can be delivered via telehealth, which is important because some adolescents may still require rides from their parents to and from appointments. It's effective. 3 large randomized clinical trials on adolescents have shown that CBT leads to greater reduction in substance use compared to psychoeducation, and it targets multiple problems associated with substance use. Motivational interviewing is a counseling technique that helps patients explore and resolve their ambivalence about changing their unhealthy behaviors. Motivational enhancement therapy is a subset of MI that was designed specifically for substance use disorders. It's a little bit different, but they're very similar. MI and MET are the most effective in mild alcohol use in adolescents. It's associated with fewer days of alcohol use per month and fewer heavy drinking days per month. The use of MI and MET and other substances for the teen and adolescent population is not as effective. Screening, brief intervention, and referral to treatment, known as ESPER, is a good intervention for adolescents with unhealthy alcohol use. The brief intervention is usually patient education, and the referral is usually to psychotherapy or addiction counseling. An important note on screenings for substance use disorder, alcohol and drug screening in this population was given a grade I, so uncertain, by the United States Preventive Services Task Force. And that means that for a regular teen with no history, screening for these behaviors, you may not be fully reimbursed for that. So the way around that is to assess for alcohol and drug use in your psychiatric evaluation. There actually are some good community resources available for adolescents with substance use disorders, and these will all be dependent on where the individual lives. One of the most obvious is overdose education and naloxone access. So luckily, naloxone is becoming much more available. There are also school-based prevention programs, kind of like how we had DARE growing up. The Unplugged program, the Life Skills Training program, and the Good Behavior Game have all been shown through clinical research to decrease substance use. Some schools offer school-based treatment. These are often called like recovery high schools. They are specifically designated schools that can provide secondary education, substance use disorder education, and support adolescents and teens who are in recovery. There's the Adolescent Assertive Continuing Care program, which I'll talk about next. And then there's also mutual health groups like 12-step programs, Alcoholics Anonymous, Narcotics Anonymous. Adolescent Assertive Continuing Care can be a good resource for teens who are really struggling with their substance abuse or who need some extra support. This is the adolescent version of ACT Team that you use in adults. It provides long-term monitoring and support and aggressive case management to give these kids what they really need. Here are just a few suggestions for different therapies for different scenarios. Alcohol withdrawal is actually pretty rare in adolescents and teens, but it does happen, so you should still be aware of withdrawal symptoms and treatment. In order to assess whether your patient is at risk for alcohol withdrawal, you really need to quantify their drinking, and that can be pretty tough in teens because their drinking patterns are often pretty inconsistent. So you may need to educate your patient on what constitutes as a standard drink size, as well as what counts as binge drinking for their age group. So depending on what setting you end up working in, you may actually treat adolescents and teens in alcohol withdrawal. So it is a good idea to be familiar with some of the withdrawal medications. Feel free to pause this slide and read if you feel like you could use a refresher. There are no FDA-approved medications for the treatment of alcohol use disorder in people under the age of 18. The standard intervention for alcohol use disorder in this population is psychotherapy. However, you will see naltrexone used on a case-by-case basis for adolescents who have severe alcohol use disorder, especially if they present with withdrawal symptoms. But the caveat is medications like naltrexone, disulfiram, acomprosate, these can all be used off-label in teens and adolescents, but they require high levels of motivation and treatment adherence to be successful. And usually that's the exact opposite of what a teenager is. They're low compliant and low motivation. So there really has to be a special patient with the motivation for naltrexone to be successful. Naltrexone is not FDA approved for use in adolescents, but it is often used off-label to treat alcohol use disorder and opioid use disorder. Naltrexone is an opioid receptor antagonist, and it can reduce alcohol and opioid cravings by blocking endogenous opioids. Naltrexone functions by blocking the pleasurable effects of opioids and can lessen alcohol cravings for some people. Naltrexone is kind of cool because there's a potential to reduce cravings for multiple substances, and this is because there are opioid receptors in areas of the brain associated with reward pathways for quite a few different cravings. Benzodiazepine withdrawal in adolescence is pretty rare, but it can happen. So once again, you should familiarize yourself with the symptoms of withdrawal and the treatment for benzodiazepine withdrawal because it can be life-threatening. The best practice with benzos is to slowly taper your patient off of the benzo over several months and assess for symptoms of withdrawal. But if your patient does present with withdrawal, you want to give them a benzo. And then once they stabilize, then you can begin that slow taper. Opioid withdrawal is something you likely will see in the adolescent population. Just anecdotally, at the clinic where I'm working at right now, we've been seeing a lot of opioid use disorder, especially with fentanyl. So just familiarize yourself with withdrawal symptoms. Know that opioid withdrawal is rarely life-threatening, but we still like adolescents and teens to be medically supervised during withdrawal because we can get them the support and the intervention they need faster. Some medications you may be prescribing for opioid withdrawal are to help treat the withdrawal symptoms. I have these listed below. And then you may decide to initiate medication-assisted therapy while a patient is in withdrawal, and this can be done with buprenorphine or methadone. Methadone is really hard to obtain for this population, so you'll see buprenorphine used the most. Medications used for the treatment of opioid use disorder depend on how severe the OUD is. So for mild opioid use disorder, the first-line treatment is always going to be that psychotherapy component, but UpToDate also recommends using naltrexone in addition to psychotherapy for this group. For moderate to severe OUD, first-line treatment is a combination of buprenorphine and psychotherapy. Buprenorphine is the only FDA-approved medication for the treatment of OUD in adolescents age 16 and up. It's available in oral, injectable, or implantable forms, and is often combined with naloxone to reduce the euphoria associated with opioid use. Dosing for adolescents is the same as dosing for adults. You just want to figure out, what type of opioid they were using, because those who are using fentanyl or methadone will need a stronger starting dose. They typically start at 2 to 4 milligrams and work your way up to 8 to 16 milligrams per day. Common side effects include sedation, headache, nausea, vomiting, constipation, and insomnia. But if a patient takes a lot, or if they take it with other substances like benzodiazepines and alcohol, it can be fatal due to respiratory depression. An additional thing that's important, for all patients, but especially for kids, the oral dissolving form of buprenorphine can cause some really bad dental problems. So you want to make sure they're receiving dental care and that their dentist knows that they're taking this medication. Nicotine withdrawal is something you will encounter pretty frequently in the adolescent population, especially on inpatient units. So take a second to review the nicotine withdrawal symptoms. We know that the first-line treatment is psychotherapy, but in addition to that, the American Academy of Pediatrics also endorses the use of nicotine replacement therapy for people under the age of 18. It is considered off-label for this population, but it comes in plenty of different formats. You can have patch, lozenges, gums, and though these are commercially available over the counter, people under the age of 18 actually need a prescription to use NRT. Cannabis withdrawal and cannabis use disorder is something that you will see pretty frequently in the adolescent population. So take a second to familiarize yourself with the withdrawal symptoms. For the most part, treatment of cannabis use disorder is purely psychosocial interventions, but recently an over-the-counter medication, N-acetylcysteine or NAC, has been gaining traction as a possible pharmacologic adjunct to psychotherapy in treating cannabis use disorder. It's actually the reversal agent for paracetamol. I'm going to put some information about it on the next slide, but there's really not enough research for this to be a true recommendation for your practice, but it is being used a lot. For all other substance use disorders, Currently, there are no clinical trials to support the use of psychopharmacology for the treatment of these disorders. So for stimulants, hallucinogens, inhalants, anabolic steroids, and sedative hypnotics, the mainstay of treatment are those psychosocial interventions that we talked about. There are a couple different options for evaluating treatment outcomes for substance use disorders. You just want to make sure that you're using both objective and subjective measurements of the treatment progress. So one way you can do that is through urine drug screenings or serial administration of screening tools. Typically, you want to use the same one that you used to first identify the substance use issue and continue to use that over and over again. Or you can count the number of substance use disorder symptoms according to the DSM-5 that they still have and see if that's improving. And another way that you want to make sure to look at their treatment is from a multidimensional picture. Are their family, school, and peer relationships improving? Are they either staying out of legal trouble, or is that getting better? Has there been a reduction in their risk-taking behavior? And, what do they think? What do their parents think? So if your patient is responding adequately, you should continue with that treatment plan for the full recommended course of treatment. So like for CBT, that's generally 12 to 20 weeks. For medication-assisted treatment like buprenorphine, that can last months, years, or maybe even forever. For your psychotherapy treatment, booster therapy sessions or regular check-in sessions throughout the year are recommended so that you can continue to reinforce those skills and prevent relapse. If you find that your patient has inadequate treatment response, there are a couple different things you can do. You can increase the intensity of their treatment. That can be more frequent therapy sessions or even a more intense type of therapy. Like before, we talked about how multisystemic family therapy is like the most intense family therapy as an option. You can add a different psychosocial intervention, so you can combine different psychotherapies or include a community resource, a mutual help group, adolescent assertive continuing care. Those are options. You can always increase their level of care, so enroll them in like an IOP program or even a residential treatment facility or inpatient treatment if indicated. And you can incorporate adjunct pharmacotherapy if appropriate. I just want to end on a quick note about combating stigma as providers. The language we use really matters, especially to teens and adolescents who are hanging on to every word that we say. So you can't combat stigma while continuing to use stigmatizing language. So just go ahead and take a look at this table about ways that we should be describing what we're seeing in the clinical setting. Thank you for sticking through this presentation with us. We really appreciate you. Here's that post test again, so you can go ahead and test your knowledge and see what you learned.